So we're going to call up our panelists, Raphael, Barbara, Kate. And then we have a few discussion questions. The presentations provided a great foundation for really how the science, the more basic science meets practice, but also on how things can get implemented at a population level. So I think that there is sort of a discussion that we're going to have that really sort of brings some of the things that we learned earlier sort of to this point about what happens sort of in the real world and how we get it implemented. So this workshop provided an overview of the current science related to nutrition during pregnancy and lactation. What do you feel are the implications of what was discussed earlier for your work and for population level health? And we can start with Kate.
Well, I think one thing, and this may not answer your question, but it's okay. Somebody said this morning about how women do really well when you give them information and educate them. And I think that we're finding that that's really true. That when we've started measuring DHA levels in the supplemented and non-supplemented group, and everybody's levels going up. By the towards the end of the last 6 weeks, it's only the supplemented group that continues. But you know, we tell these women that they're in a study about nutrition and fatty acids in particular and how important we think they are. That's why they're in the study, and they're either going to get placebo or fatty acid. And I think that people are taking their prenatals and probably eating more fish, and we have the data, but I think that we sometimes underestimate the power of education.
Barbara.
I've been thinking a lot about yesterday, and I missed most of today, but we really do want to continue in some of the work that we're doing both in San Francisco and mindfulness. And yesterday it struck me, what would the most beautiful kind of menu or diet be given all the speakers yesterday? And I was particularly struck by choline, for example. You have to eat 8 eggs to have the recommendation that the speaker spoke about. And there's so many women that are undernourished. So I think we'd have to do more in providing food, and what would that food look like, especially with the backlash of findings in the media saying, eggs are bad, butter's bad. So just the messaging, the preferences, and what a real healthy diet would be, and to really try to communicate there really isn't any room for highly palatable foods, which there was just a study out that tried to really define clearly what is a highly palatable food, and they have very clear definitions, and then they looked at the USDA's database and identified that 62% of the foods in the database, which is a reflection of our food system, our food supply, met the definition of highly or hyper palatable foods. So we're just up against a lot. So that's kind of what I've been thinking about.
So, first of all, I have received a wonderful update from my basic scientist, clinical research colleagues, and it really reinforces the notion first that it is impossible to understand maternal child nutrition if we don't understand the microbiome and how it shapes the impact or modifies the impact of the diets that we consume. But on the other hand, a very powerful statement was also made today that we really don't need to wait until we know the last detail of the biological mechanism that explains some of these relationships. I think we have enough knowledge to actually make sound recommendations regarding to healthy dietary and physical activity patterns. I think that the presentations collectively, what they confirmed, at least to me, is that we should really try to stay away as much as we can from single nutrients or single bioactive compounds or even single food groups. At the end of the day, what is going to matter is the overall dietary patterns across the life course of individuals, what I think will determine, the health of the vast majority of women, pregnant and lactating women.
So I think for me, what I've really taken away from these past 2 days, and I've been both very encouraged by how much we do know about nutrition during pregnancy and lactation, and also kind of excited and scared by how much we don't seem to know about it, which I think provides a very great opportunity for science and research moving forward. As it relates to WIC, I think that these last 2 days have confirmed my conviction in the sound science behind the WIC food package and how the foods that are given to WIC participants are tailored around the nutritional needs of that life stage. So a pregnant woman is getting a different food package from a breastfeeding woman, from a postpartum woman, from the infant and the child. But at the same time, there are opportunities for us to try and strengthen, both from the perspective of NWA and to the WIC community at large, for adding maybe certain foods that could better support certain nutrients. I know we keep talking about choline, but choline really struck me yesterday. And we actually did have a call with Marie a couple weeks back about the importance of choline, and just realizing that we don't even, if I'm remembering right, have a biomarker. There's no way to really measure it in your body. But at the same time, we know that this is really important for pregnancy. And so I think that those were the implications that I took away from the last 2 days.
So in thinking about that and considering your extensive experience in practice or in community research, and this question came up earlier with other panels, when we think about what's needed, if we want to improve nutrition during pregnancy and lactation at the population level, at this point in time, do you have a recommendation for what do we need to do right now to improve nutrition and during pregnancy and lactation and really bring it to the population level? We can start anywhere. Yeah.
I'll start. So in my office, our CEO and a number of us have this crazy dream called Go to WIC. So what would it mean if you could expand WIC so that it's not only just addressing women, low-income women, but women nationwide? What could we do if you can make it applicable to all pregnant women, all breastfeeding women across the nation, regardless of your income? So not that could happen immediately or probably even within the next 10 years, who knows? But I think from the perspective of NWA, we clearly stand behind the research that supports the WIC program and how it is beneficial. And so what are ways that we could somehow scale it up so that all women can benefit from it?
So I think what the GEAR model would call for is better coordination among food and agriculture sector, with health sector, with social protection sector, with education sector, and so on, to integrate much better the services and improve the coverage, the quality, the economic efficiencies with which those services are provided to pregnant, lactating women and their families. We really need to stop seeing also separately the babies from the mothers, and also both of them from their families, and their families from their communities. That requires a much more intelligent management information systems for this to happen. I also happen to think that, the policies, the programs, and so on are Band-Aids. Some of them have Gorilla Glue, and they're very powerful, and they will stick very strongly. But if we want to solve this problem in the long term, everything is about addressing the social determinants of health. So I had the luck of working very closely with the government of Brazil between 2013 and 2020 or so with regards to the evaluation, the design of their food security policies. During that period, the level of stunting, for example, dropped dramatically in the country, and socioeconomic inequities practically disappeared at a time when in the rest of the world, low and middle income countries, those inequalities kept on growing. When the government did commission the analysis as to what explained this, obviously they wanted a result that said, oh, it is because the Fome Zero program, it is because the small family agriculture program, or it is because the universal healthcare system, or SUS. But essentially what the results shown of that modeling was that 75% of the reduction in inequities was explained by economic growth with much more equitable distribution of the wealth that was accumulating, dramatic increase in minimum wages, and very low unemployment rates. That explained 75%. We don't know the mechanisms. We don't know how much was through improved food systems, how much it was through reduced crime and stress, and about 25% could be attributed to these billions of dollars that were invested in more equitable social policies. So I don't think we should fool ourselves. I think in the long term, if we don't address the social determinant of health through an equity lens, we're not going to be able to solve this very serious public health problem related to the lack of access to healthy dietary, physical activity, and mental health state for many low-income women and families in our country.
Big question. I just feel like we're up against a big challenge without somehow addressing the food supply. I just don't know how individuals, especially lower income pregnant women, can really navigate the limited access to nutritious foods every day. You know, we're supposed to be eating upwards of 7 to 9 fresh fruits and vegetables, and on average we're eating maybe 2. So, and you look at the NHANES data, and Americans, not just low-income Americans, but Americans across the board, are scoring very, very low. So I just don't know how we really move forward without a healthier food supply. And other nations across the globe can do it. I just don't understand why we can't.
I feel like I struggle with the tension of focusing on pregnancy. I mean, for me, for my research interests, it provides a really nice opportunity to engage with women, because most women come for prenatal care. And most women are kind of ready for uptake of educational information. But it also seems like it's such a burden, like, okay, you're pregnant and now like the health of the nation is on you, and and it's all about you're a vessel for this person, and we want to improve that person's health. And so that's a tension for me sometimes. Like if we shifted it to, I don't know, early child, the health of the nation of the early childhood period, if we set these patterns in motion early and engaged people on multiple levels, that it would just kind of roll out. But I don't know the answer to that. But I do feel sometimes like when it's a problem of women or women and their babies, it just separates it from everybody else, can kind of forget about it. So I don't know how to deal with that tension, but it's something I think about.
So this is the last question before we open it up, because we're going to run out of time. But I think thinking about that holistic perspective, because when we think about the population level, we think about a holistic perspective that doesn't only have to target, I think Raphael mentioned this, it's women that are pregnant or lactating, but also they're in the context of families, they're in the context of communities. So when you think about the types of things that we need, like what models do we need to make sure that some of the findings that we do know and those that are to come can be implemented. What models do you suggest or specific approaches to reach that population level? Because one is that we do have some science, but as we learned, things are emerging. But even as they emerge, at some point in time, we have to implement that. And I think Barbara mentioned we already have some challenges in implementing what we know up to this point. So what would you suggest when it comes to, or what would you recommend when you think about specific models where we could take some of the nutrition recommendations and really implement them at scale? And maybe we can, anybody who wants to answer.
So I don't necessarily have like a new model in mind per se, but when I was thinking about this question, I had policies and programs that I think have been working really well that multiple speakers have touched on over these last 2 days. So iodization of salt, I think, is a big one. It's interesting because when I think about, or even fortification of grains with folic acid, fluoridation of water, we didn't talk about that at all, but like these programs where we're somehow trying to add some type of nutrient or mineral to the food supply to try and improve population health. And when I think about these programs, it sometimes like makes me start thinking about vaccines and how when I was a toddler, I had a boomer father who took me to the doctor literally every week. I feel like my entire toddler years was at the doctor getting a shot because he came from a generation where he saw what it was to have polio or what it was to have measles. And when you look at my generation of parents where you don't see those things anymore, so you start to question why we even need them. And with nutrition, I feel like we're kind of in a similar spot, but less skepticism as much as why do I need these things? And so when you try and you start providing sea salt, Himalayan pink salt, more people are using kosher salt. Those things are fine, but then what is the implication when you're not getting as much iodine? What's the implication on future generations? When you have been told that gluten is bad for you, so now you're not going to eat gluten, and where's the folic acid going to come from? So I think that those are good examples of programs and policies that were implemented that improved health. But what are ways, I guess my question to your question is what can we do to kind of reinforce that among the population? Because, the goiter belt was around the 1920s. The only people alive that would know what that looks like are centenarians. So, what does it mean to try and remind the population that these nutrients are important? And just because you don't see the ramifications of the deficiency doesn't mean that you don't need it.
Raphael, we'll take this one last comment and then we'll open it up.
Yeah, so I couldn't agree more with what has been said, and especially with Barbara's point about without changing the food system, there is not a whole lot of hope. The hope that I see is that in many different states, I'm seeing very interesting local food systems initiatives that are very much grassroots and are coming from the communities themselves. We have a very interesting system in New Haven, for example. I would say that if we were to empower those movements more, those systems more, if we invested more in citizen science and allow them to communicate with each other and share with each other know-how and move together as a single front, that could probably be an intervention that could end up collectively making a difference in the country where it is very tough because unfortunately we don't live in a political system that facilitates that from happening. It's going to have to come from the bottom up, I think.
So at this time, I would like to open it up open up the discussion to members of the audience. As a reminder, we also will be taking questions from those that are viewing via the webcast. So we ask you to please state your name and your affiliation when you ask your question. And I know we have our first question.
Cindy Turner Maffei with the Healthy Children Project. thank you all for tackling a really tough topic. Not that they haven't all been tough, but making it work on the ground is really hard. And I just wanted to emphasize what Darlena said about the Go to WIC idea. When I first heard that idea, I thought, yes, I'm biased. My roots are in WIC. And then when I moved out of WIC into the community, I saw how families struggle to find breastfeeding help and forget about nutrition help. That's just, if you're $10 above the WIC income cutoff, where are you going to go for help with those things? We do have some remnants of volunteer breastfeeding counseling in our communities. We have really no reliable nutrition volunteer counseling that I'm aware of across the country. And I think, it's wonderful that we have breastfeeding support in our healthcare system, but we've invested breastfeeding help in our most expensive sector. And so how does that correlate to supporting women over the months and perhaps years that they could be breastfeeding? And so I'm just wondering if panelists have models from other countries of how nutrition and breastfeeding counseling is provided in a community way that is more available to all and also less cost intensive than what we have right now. Thank you.
So I'll try and answer the question. So I don't know that there's necessarily, in my mind, I don't have a model for one specific country. But I think when you look to, I guess, the broad, like the South American continent, Africa, they breastfeed so much more because it's just been so ingrained into the culture. Whereas when you come to the US, it's one of those things where we breastfed at one point in time and then it was stripped away from, slavery, Black women. A lot of that history contributes to why the breastfeeding rates are so low within that population. But then at the larger population, this notion that somehow formula was going to be better for you than what your body could produce. So I think for me, not necessarily having a model, but like a suggestion is, or what can we do to try and restore breastfeeding to the way it used to be, where you didn't having an IBCLC would be great, but like your mom had breastfed, so you would know, she would know how to help you out. Your sister breastfed, your friend did it, where there was just so much more breastfeeding culture that you didn't always have to rely on the breastfeeding professionals who went 2 years of school and education. Obviously, there will always be those women who need the IBCLCs, but for the less severe breastfeeding issues, having that community I think is so important, and that's something that we don't have in the U.S. But I think other countries across the world have it so ingrained in their culture that it's just not really an issue for them. So.
The only thing I want to add, I completely agree, and maybe we can be hopeful because now we have, 85% of women initiating, and it's growing. But we really need maternal pregnancy leave. We need maternal and paternal pregnancy leave. I think that would really push us forward. We're the only country that doesn't have it among, developed countries or Western, however you want to say it. And California is working towards that, to have some kind of paid leave, but we really need to see a national policy.
Did you want to say something, Raphael? I know.
Well, I worked with the Breastfeeding Counseling Guideline Committee from the World Health Organization, and we tackled specifically your question. So I urge all of you to read the guideline. We were able to identify the minimum number of contacts and the timing of them. We know very well that between late pregnancy and the first 2 weeks postpartum, if women have access to the support, then the vast majority are going to do fine thereafter. If they don't, that's where it gets super expensive because they're going to need many, many, many more visits. So also the use of technology like telehealth, text messaging, and so on. But at the end of the day, even though the low-income countries cannot afford the IBCLC model, there is a need for very well-trained, qualified people that know lactation management inside out to supervise those systems.
So I have a brief question around WIC eligibility. And just out of curiosity, has anyone ever done a study looking at kind of how much resources we pour into eligibility determination? and what it costs us to do that versus if we lighten the load on eligibility determination and kind of opened that nutritional capacity a little bit more, both for issues around documentation as well as just like, couldn't we come up with an audacious idea of, even if it's something as simple as linking like 4-H clubs, Future Farmers of America, WIC, and USDA. Boy, that kind of covers everything from 10-year-olds raising cows and vegetables to, senior policy decision makers doing stuff. I mean, is there a way that we can maybe think creatively about resources and what we require to decide somebody deserves food or they don't deserve food?
Yeah, that's a great question. And so if I were to summarize your question, then what you're asking is anyone exploring better ways in which we can lessen the amount of paperwork that participants need to bring in to be enrolled onto the program? So I think first I'm going to tie back to the slide regarding the WIC Act. So I didn't go into too much detail because limited time, but when it was talking about extending infant certification periods, it would be from 1 to 2 years. And one reason why we pushed for that is because it is a lot of paperwork that you do have to bring in. You have to bring in a birth certificate to, verify identity. They don't have a license. You have to bring in your income. You have to bring in your mail. You have to bring in a lot of stuff. And so by extending it by that 1 year, that is one way in which we can alleviate that burden for our participants. We have had multiple discussions. One that always comes up is there a way you could share your database with Medicaid? If there was a way that you could link to food stamps, because, if you're on WIC, Medicaid, and food stamps, you're bringing in all the same paperwork to 3 different programs, and it is very burdensome. I think that basically we haven't been able to figure that out yet. But I think that especially within our office, that is something that we really do want to work towards, because that is a lot that we're asking participants to bring. And we know that it even impacts when you're giving out nutrition education materials to participants. They don't want pamphlets because they already have to carry in so much stuff to the appointment that giving them any extra is a disincentive to them. So having this paperwork and all this stuff that they have to bring in is even impacting, their capacity to necessarily absorb that nutrition education information. So we are looking into ways. In terms of specific research, I don't know any of that, but we do have Georgia Machel in our office. She's the Director of Research and Program Operations, and I can give you my business card so I can put you in touch with her. We also have the WIC Hub. If you go to www.thewichub.org, you can actually Google in topic areas, and it'll show you the WIC research that's been out there. Yeah.
And I could just say 2 things. I don't know. One is automatic eligibility for people that receive SNAP and Medicaid, where you can show that you participate in Medicaid. I think the other good example of that is the National School Lunch Program, where there's community eligibility. And so I think more, as was discussed, as policy practices and programs, but those policies where it lessens the burden, where you have automatic eligibility. I think they've seen a lot of positive results from the community eligibility with school lunch. It's reduced stigma, and where you don't have to verify. There's where you have high community eligibility of people that receive WIC, that could be a possible model where you have community eligibility versus individual eligibility.
And I just wanted to touch on, I forgot to mention that we do have adjunctive eligibility in WIC. So if you are on Medicaid or food stamps, you can bring in your card, and that will count as your proof of income, with the caveat being you still have to bring in mail and other things. So, what are ways in which, we've lessened the burden to a certain extent, but what else can we do to make it less burdensome for our participants?
This is more of a comment just on that topic. And I know only a little bit about it because I went to the information session as a healthcare provider. But the state of Virginia rolled out their Medicaid expansion last year, and they tried to do some things like what we're talking about to really facilitate enrollment in lots of different ways, whether they're the free and reduced lunches, or if you're already on WIC. So maybe you want to look at the rollout of Virginia as an idea.
Yeah, we're in Texas.
No, I mean for ideas to, just as an example.
So do we want to take some from the web, or do we want to?
Oh, I have a question though. Besides
Oh,
what's on the-
okay. Yeah.
I know I look like the webinar, right? So what I wanted to sort of follow up a discussion that we've kind of heard some of the theme here is saying that community participatory research is very, very important here. And the notion that, in fact, we're not talking about equity. We're talking about there's inequities. And so there's different communities that need different solutions. Mm-hmm. And I'm wondering, to what degree do you think that there's hope in us being able to allow for that tailoring, both at the state and federal level when money flows down, so that communities have the power to say, this is what we need to be able to lift up our community to be able to have these beneficial effects?
Raphael.
So one of the things you hear the most from communities that have been affected by historical trauma, like Native American communities as an example, is how whenever someone goes to their communities to find out solutions and so on, they always see them as if there's something wrong with them. You guys have a problem. We need to fix you, you know. And that is exactly, you know, why constructive, assets-based, community-based participatory approach, as you're mentioning, is needed, Ana Maria. I think that all the communities have enormous assets. They have knowledge, they have traditions, they have experienced what has worked, what has not worked in the past. So the good news is that the emerging field of implementation science in nutrition, which now we have a formal society on implementation science in the field of nutrition, calls precisely for not implementing programs anymore without having done the step of consulting with the communities, not only what are the needs, but what are the assets and what are their preferences, how they propose for these issues to be addressed. So in implementation science, the big tension is fidelity versus adaptation. So on the one hand, we want to know which are the core functions of the programs, which are the aspects that if they don't get implemented the way they are in the guideline, they're not going to be effective. On the other hand, we have to recognize that complex adaptive systems has a dimension that is called path dependence, that it tells you it's impossible to do it exactly the same way in every setting. So one of the most promising areas for future research in implementation science is identifying which are reasonably allowable adaptations based on needs, assets, and wants of communities, and which ones are very core functions that should not be sacrificed under any circumstances. Without the formative work, the CBPR, we will never be able to do that in a smart way.
This is a perfect segue, because I was going to share that I'm conducting a pragmatic trial in the Louisiana WIC program, and it's a statewide randomized trial. It's NIH funded. It's got a big number, like $3 million or something as the price tag. And we spent a year and a half doing formative research with key stakeholder groups. So we had community advisory boards, but the most important stakeholder group was the group of WIC mothers who came and poured into us about what it is that they wanted to see in a program to improve their health. You're going to have to look really far to try to find a woman that is not going to tell you, or that will tell you that they're not interested in the health of themselves and the health of their babies. You won't find somebody telling you that. They are invested. They know what the message is, but they don't know how to implement it. And I think that this goes beyond WIC. And if we think about physical activity and the physical activity conversation, we think physical activity is so important that now we're requiring it back in schools, right? 1 hour a day of physical activity in schools. We need to go back to schools, and we need home economics, because what we've learned from these mothers, they don't know how to use their WIC foods. They're really intimidated, in fact, by some of the foods in the WIC package. So we've made recipes and cooking cooking demonstrations and classes that are all online, but we would never have learned that if we didn't engage them in conversation. So I appreciate the comments about community participatory research, and I 100% agree. Until we know what it is that they need, we can't make programs to address that.
Thank you for saying that, because I really appreciate the whole thought arc. And one thing that I struggle with is seeing the disconnect between knowing about food and knowing how to cook and knowing da-da-da-da-da. And we've talked a lot about adding kind of a home ec type thing. So what I struggle with is, how do we go back to the future? So how do we go back to some things that really worked in our very recent past, like home ec classes and, just gym and play and all these things. And then how do we implement them, think about them creatively, think about them in systems, and be ready to do something new? Because we're kind of stuck in these really rigid systems, and the teaching to the test and the food system, and just accepting that there's going to be 4,000 new foods that are all highly palatable on the market every year. So how do we kind of reverse all of that and try to be nimble? So I really appreciate your comment.
So with that, because it's 4:00, we need to conclude this session. I want to thank each of our session speakers. Thank you so much for participating. And then now we're going to move to the final session of the program. Thank you.